Right, thank you very much. My name is Howard Simpson. I'm a consultant in the emergency department at Basingstoke and at Winchester, and I also have responsibilities for the provision of the minor injuries unit service in Andover. It's my great pleasure to come here this evening and share some of my perspective on the provision of emergency care in this region. And I thought I'd give it the snappy title of The Myths, Magic and Mission of Emergency Care. And what I'm hoping that by the end of the evening I will have explained, and these are your sort of take-home messages, are that we are constantly evolving to try and meet the need of people like you, like me, who actually live here, because we are a service based within a population to meet those needs. I also want you to understand that busy does not equal chaos, and likewise, chaos doesn't prove that we're busy, if that makes sense. And the challenge is to become busy and effective in a non-chaotic way, which takes a little bit of time, a little bit of planning, and a lot of understanding. Also hoping that you'll see that the service that we provide is part and parcel of what happens outside of the hospital and within its walls. It doesn't exist in isolation, and I've often challenged people to think, what would an emergency department need to look like if it were a standalone unit? And it's almost impossible to describe, all right? It's almost impossible to decide what would actually need to be within the walls of an emergency department if it were standalone. It would either have to be something like Camp Bastion, which is not really an option unless we want to have that level of trauma on a regular basis, or it would look like the facility on a cruise ship, where you can actually manage patients for about 3 days before you get to the next port of call, or you can safely resuscitate them pending a helicopter to come and whisk you off. But neither of those is like the service that we have. And we are part and parcel. You cannot look at what we do in isolation of what's happening elsewhere. And I'd like to understand that our success in the future is about developing the networks and key pathways so that people get what they need in the most timely, effective way. Some of which you can deliver wherever, in all the sites, and some of which you need to deliver in concentrated sites so that you can actually do that safely and effectively. And the final bit of the feedback, the final bit of our message is that we need your feedback, because we've learned over the years that we'd like to think we know what's best for patients, but we don't always get that right. And whereas things like operations now, we make sure informed consent, we have to know exactly what we're planning to do and what the risks are, and we have to know that you understand those and you're happy. So in a sense, we have an advisory role rather than a paternalistic, we know best. And that probably extends as much into the way we deliver our service as well. At the very least, we need to know what you want, what you value, and whether it seems to be working from your perspective. So we'll see that at the end and see whether I've actually managed to talk anything remotely like that. But before I go on to the myths, I thought I'd just spend a few moments reminding us of the history of emergency departments. And I always smile when everyone calls it casualty, because you cannot get rid of that term. And that's fine. I'm ugly enough and old enough not to worry about that. But it's actually, our service has only really existed for about 50 years. And it was in the late 60s that what used to be the sort of the gateway into the hospital became organised into casualty units. So, and they started appointing people to the College of Casualty Surgeons, the Association of Casualty Surgeons, and they were people who were bold enough to take charge of those casualty units. Because prior to that, people would just turn up, hoping that someone would make them better. The hospital was seen as a place of safety, And you know, if your GP had sent you in as a patient, that's fine, but if you didn't, you would turn up as a casualty. And most of the problems were physical injuries, because there wasn't really any service for dealing with that otherwise. But there were also the people who were poorly, who needed to come into hospital and get sorted out as an inpatient. But if you think 50 years ago, the treatment options were fairly limited, right? They didn't even know the structure of an immunoglobulin at that stage, right? You know, and yet we now can. Sorry, I'm distracted. We won't go down that line. But the technology, fair to say, has come on considerably. You know, X-rays are a luxury now. We can do CTs any time of the day or night. We can get MRIs done most days, most times. Lots of diagnostics, and the expectation is that much higher. So, you know, and even in my clinical lifetime, I started here in Basingstoke in 2000, September 2000, so I've been here 15 years, and that's gone from a one consultant-led department to one which is now partnered with another hospital, and between the two sites we've got 10 consultants. But the expectation has changed completely, all right, and we'll come to that in a moment. So I just wanted to lay the seed, but if that's what people's experience is, even only a few years ago, things are very different now. So I wanted to spend a little time just dispelling some of the myths, because when people say casualty or accident emergency, A&E, emergency department, they tend to think that it's full of drunks, full of time wasters who should have gone to see their GP. And part of me goes, why should they have gone to see their GP? Well, it sounds like they don't need to be anywhere at all. They just need to know how to manage their problem. Why offload it to the GP anyway? But I'd like to say, actually, that's not really the case. It's not jam-packed full of time wasters and full of drunks, because what I will mention a little bit later is the fact that we've redesigned the way patients are managed when they arrive, so that around 65-70% of patients that attend are actually those that walk into the emergency department. And I'm talking about Basingstoke here because that's our catchment area. And of those 65 to 70% of people that walk in, of those, approximately half can be directed to our GP, who is resident and working 24/7. The demand for that service is maximally between about 10 in the morning and 8 o'clock at night. And very few of those get turned away by the GP saying you shouldn't have come here. It's just that they have the skill set to manage those patients better than we have. I mean, I'm not a GP. I'm married to one, and I can't think of anything worse to do. Right? That's because my brain likes to have diagnostics and all that sort of thing to help reassure me that I know what I'm dealing with. They deal with problems in a different way, and I'm getting the hang of it, sort of meeting in the middle in terms of sort of working with the patient and making sure that they own the plan and they can come back if there's a problem, and they can go away with this treatment. And so we sort of negotiate. A package of care. And anyway, so moving on, the time wasters, we're not full of time wasters. We do get a few, but they are actually vanishingly small. Full of drunks, yes, okay, yeah. Friday night we do get quite a few, but they are there because they've been injured because they're drunk, not because they just want to come and party on. There's another myth, is that we are chaotic and unsafe, that the waiting room is full to the gunnels with patients and limbs here hanging off, and actually that's not true. And most of the time, if you come in, our waiting room is relatively quiet and relatively well controlled. The problem comes is that people, we can see and treat 5, 6, 7 patients an hour, but if they arrive at 15, 20 an hour, then they're going to have to queue until we can get to manage them. So the peaks and troughs tend to iron out with time, but we can't always see everybody straight away. And so the waiting room is really just a buffer, a capacitance, so that we can take people and manage them in priority. Another is that we've got a staffing crisis going on. Now, we do have a staffing problem going on, but it has been slightly bigged up in the press. And the reason I'm standing here in purple pyjamas is I wanted you to know what a consultant in the emergency department looks like. Because if you are unfortunate enough to come and need our services at a weekend, this is what I will look like. All right? You'll be able to recognise us. We look very similar to the other doctors in the emergency department, except we have our Flash Gordon badge on, which says we're members of the College of Emergency Medicine and fully trained. And we, in our department at weekends, we will be there for a minimum of 10 hours per day at weekends. All right. And for the number of consultants per department, that is 5 here, 5 at Winchester, we actually provide the greatest cover at weekends by consultants than any other emergency department in Wessex. There are problems recruiting junior doctors. We get junior doctors through by rotation as part of their programs, but unfortunately there's a lot of doctors who don't want to train in emergency medicine, and so we're having to be very creative in terms of finding ways of meeting your needs. And one of the things I'll explain later in our magic slide is that we are very creative at using other people other than doctors to manage the problems that we need to deal with. And the final thing is that there's this belief, which is very flattering, that we can do anything and everything. Right? And some people believe that's what A&E stands for, anything and everything. And yes, we sometimes would like to have a go at anything and everything, but actually it's probably best that we don't, and that we ask some of the more specialised clinicians in the hospital to come and help us out. And that's again the point I wanted to make about what would a standalone emergency department look like. It's very difficult to run an emergency department without being attached to a hospital, because actually we need the expertise and resources of the whole hospital in order to help us function. All right? But what we do provide is that that safe area while we work out exactly what's wrong. Sometimes we've got very little time in which to do that, i.e. to resuscitate, to make people safe, to keep them alive long enough to know what the problem is and make them better properly. But we are in charge of that resuscitation process. We're in charge of initial investigations, things like pain relief, diagnostics of the blood tests and x-rays, history and examination, work out what the problem is. Even if it's obvious you need to come in, we've got to know who you're going to come in under. Is it a medical team? Is it a surgical team? What is the problem we need to address? And that's where we are particularly skilled. So yes, we can do, or we like to think we can do anything and everything, but not without the support of everybody else. So I put this slide in mainly to see Mary's reaction, because I'm not actually going to do a magic trick for you. Oh. No. But it's almost as if people believe we can do magic in the emergency department. Sometimes the mystique around our workplace is extremely flattering, and yet again we're on the front page of your booklet, all right? There's someone in purple pyjamas being somehow symbolising the hospital and its activity. And it's fascinating when people sort of rush into the emergency department. They manage to come up by car, they run in, and they hope that the receptionist is going to make them better. It's fascinating that there is this aura about the department that it is a place of safety, and actually it is, right? It's on a regular basis that a mum will run in with a child, and the receptionist will open the door and take them straight through to resus. They know they're up for this. Right? This is why people come to this place of work, because that's part of what's expected. Our challenge is to meet that expectation, and what we've done recently is try to stream the activity. So rather than one place does everything and then finding that you haven't got enough time and effort or space to try and manage everybody. Because what would happen a few years ago is that if you came in with a cut thumb, people would say, you've only got a cut thumb, you will have to wait because there are other people who are more important. The trouble is you could be waiting all week and there will still be people coming in who are more important than you and you won't get seen. So how do we square that circle? And the answer is to split it into two. So you have one area for walk-in patients and those that are brought in by trolleys. And then your assessment and your management is within the walk-in service, it's front of house service, and that is geographically separate at the moment with their own consulting rooms, and that's where our nurse practitioners play such a key role. So these guys are trained to manage the sort of conditions that come 9 times out of 10 walking in, and if it's more complex than they can manage, then they pass them either to the GP or through to the walk-in area where they'll get a team of doctors and nurses with more diagnostics to sort you out. The third bit is the short stay facility, which we've used successfully for some years, so that when patients have got a relatively self-limiting condition, be that a cellulitis, an infection of their leg or their hand that needs antibiotics, or they've taken a relatively benign overdose, they need to make sure that it gets out of the system and then to see the mental health team. Or they are one of those drunken people who came in on a Friday night, they've had a head injury, they're not safe to go home, but we can look after them until the morning. There's also elderly patients who come in the small hours of the morning, and there's nothing that would need them to stay into hospital, so we'll give them bed and breakfast. There's no point in sending someone home at 2 in the morning. It's very disorientating. So our short stay facility has been in operation for some years, but we're looking to expand that geographically to include patients who don't actually need the bed. So there's a sitting area, an ambulatory area to manage those patients. It gives us more capacity to do more with. The next bit about our magic, all right, and the things that we're doing different things with than perhaps you might expect, is that we're working with our GP colleagues. The question here is this demand because they don't work at night, because we've got a cooperative, and well, there's lots of reasons, but it's not an either or, all right. And I think one of the problems comes is the organisational boundaries are in the wrong place, all right. This is how do you manage people who've got problems they don't know how to manage. So they don't know whether to come to the GP, to the emergency department, they don't know whether to call 111 or 999. So let's not get hung up about it. It's not about pushing the patient into the right place, it's about joining up the network around them. And starting with the GP is really important. We also need to, we also work very closely with our medical and surgical teams. So it's not just about, well, you accepted them, you manage them. It's about, well, these are sicker ones and we need to help you. Likewise, we've got a patient who needs to come in. We don't need to do too much. Come in, just make the process fast. So we're trying to streamline the flow of patients. And as Mark will be talking about very shortly, if I can actually get off the stage, is that we're linking up with the services in the region. Trauma networks I think it's a game changer actually in terms of health provision. It has been exceptionally good at showing how you can do things differently, despite involving absolutely every part of the hospital, in every hospital. Everything from paediatrics to orthopedic surgery, everybody has had to buy into this, whether they like it or not. And I think also just the final bit about the magic is just from a personal statement that there is something magical about working in this environment, because it's very privileged to be able to meet somebody who I've never met before at a very desperate time in their lives. Nobody plans to come and see me. Everybody who sees me is having a bad day by definition. and within 10 minutes they're telling me all sorts of things they probably never told their neighbour, or sometimes never told their family. And I have to handle that with respect and confidentiality, and sometimes I have to explain to them I can't do much for you, you'll be fine, or sometimes I can't do much for you and you won't be fine, but that's the way it goes, and you have to have some very difficult conversations. Likewise, I have to tell them, you know, I'm going to have to do something unpleasant to you, stick needles in you, cause some pain and discomfort, and they have to trust me. And it continually surprises me that they do. And perhaps the more off the wall I get, the more they do, because actually it's not about meeting the expectation of what a doctor should look like, it's actually meeting the expectation what a fellow human being is and understands. So thank you for letting me carry on in this job. Finally, our mission. All right, sometimes it feels like mission impossible. But what I would like to say is that in the next few years that we not only stay good, but we manage to become better. I think one of the ways that we're going to do that is by making sure that the vast majority of patients who come in fit recognised and clearly defined pathways of care. So in other words, their journey is not unique, their journey is not tailor-made for them, but it fits onto a pathway that other patients tread. All right? It's a pathway because so many people follow that route, and we've got to make sure that route is clear, unobstructed and effective, and it doesn't cause them any harm. So that pathway must work, and it's our job to make sure that it works. We can do that for things like strokes, we can do that for things like headaches, which are within our own scope. So you may be aware that patients with strokes need to go to Winchester. So did I say headache? I think that was a mistake. So strokes go to Winchester because that's where the stroke centre is in our catchment area. But patients with heart attacks, sorry, Andrew, that would not headaches, they don't come to you. Although they do, yes. But the heart attacks come to Basingstoke, where all that kit and the expertise is focused so that we can replumb your heart and keep it ticking for some more years to come. That's within our sphere of influence, but there are other things like trauma where we tie in with the regional services. Cancer is another, and I'm sure there will be more that we need to do regionally and within our catchment area to get the best out of what we have. So that configuration and the focus on how we deliver it is, I think, in my mind, our biggest challenge. And ultimately, and I think we can lose this focus in hospitals, it's about working with the communities. Right? Having lived in this area for 15 years, I do feel it's my patch. And it's weird because now I look at the junior doctors completely differently, because I realise that they are the ones who are going to look after me in the years to come. Hopefully a few more than it sounds, but they are the ones who are going to look after me. And actually, it's not like there's sort of one wall and I'm a doctor, you're a patient, and we're on the other side. Yeah, it's actually, we're like goldfish, we're all in the same bowl and we swim around, and it just so happens that at this time I'm on this side of the bowl and you're on that side of the bowl, but it all passes round, okay? So it's in everybody's interest to make sure this works well and we work together. So my take-home messages that I was alluding to, let's see if I've done my job. I think we are constantly evolving to need. The demand is changing, and we are changing ourselves. Busy does not equal chaos, and we don't have to be chaotic to justify our existence. The trick is to be busy and calm. We need to integrate with other services, both within and outside the walls, and networks and pathways, so that we know exactly what needs to happen and make sure that it does. I think those are key, and it takes an awful lot of pressure off everybody. We do need your feedback, because as I say, we might think we know best, but unless you tell us, that could be misguided. So thank you very much. Any questions, we'll save till later.
Another technology challenge.
Great, can I just check you can hear me all right at the back? Yeah, fantastic. So I'm Mark Ainsworth-Smith. I'm better known as Maz. It's far easier. Maz from SCAD, most people now call me. I'm the consultant pre-hospital care practitioner with South Central Ambulance Service, and I've been leading on major trauma for the last few years. So I'm just going to talk you through what we've been doing with major trauma. The aim of the session is, first of all, I'm going to give you a bit of an overview about trauma networks, and I'm not sure if everyone's aware, but since 2012, you're not necessarily taken to your nearest hospital. You're now taken to dedicated trauma centres where they can manage you if you've got really complex and dangerous injuries. I'm going to tell you a little bit about how our crews decide which hospital to take their patients, and we'll cover that briefly. And then we have got some fantastic headline news, which obviously I'd like to feed back to you at the end of the session. In terms of major trauma, there are 20,000 cases of major trauma every single year in England, and a vast majority of these will be young. The vast majority of these will actually sit in the under 44-year age group. So it's very important, as they're the ones that pay taxes, that we actually look after them well when they're injured, so that they can actually regain some function and get back to work. Of those, there will be 5,400 deaths. Every single one of those a tragedy. Last year alone, 1,901 people died on the roads in England alone. Every single one of those is a tragedy. And behind those, of course, is a number of patients who are terribly injured, who will never ever recover. And it's a terrible problem when we look at it in that way. In terms of economic output, we basically have looked at trauma, and the Department of Health figures say that it costs about 3.3 to 3.7 billion every single year to deal with patients with major trauma. This is a huge expense, and clearly something to do with prevention would be really good here. Trying to reduce people injuring themselves at all would actually be a great start. It might put me out of work, but I really wouldn't mind that. And in terms of SCAS, so South Central Ambulance Service, we cover a huge patch. We go from Milton Keynes across to Banbury and then all the way down to the south coast. But we did some calculations and we found that there would be 5.4 cases of major trauma every single day across the South Central region. And it's been estimated that for everybody that dies in an accident, it costs us £1.6 million per case. And people will say, well, I know Howard's really expensive when he's in at the weekend, but how can it be that much money? The reason is that if somebody's really seriously injured in a road accident and then sadly they die, of course there's some medical costs there, but we invest really heavily in our young. We put them through education and we put them through lots and lots in terms of health and make sure that they're well. And then of course what we hope is that for the next 67 years or whatever it's going to be in a few years' time, they're going to be going back to work and repaying their taxes. And of course if you lose that, then that costs us as taxpayers an awful lot of money. And the calculations come from the Department of Health, £1.6 million per case. And you can imagine if somebody's terribly injured and can't go back to work and requires supervision and care, you can quadruple that very easily. So there's a real focus on trying to improve the care of patients with major trauma. So I guess we should classify what major trauma is. Major trauma is actually, thankfully, rare. It's that red slice in that pie chart. These are patients who have what we call an injury severity score of greater than 15. And I'm going to show you in the next slide a real patient who I dealt with who had an injury severity score of greater than that. But what we can actually do is to score trauma patients to help decide where they need to go, whether they need to go straight to a major trauma centre, whether they're likely to die, whether they're going to need intensive care, how they're going to get on. These are patients who are simply very complex. They're typically multi-system injuries. Below that, we've got that yellow slice in the pie chart, and those are patients who are still very seriously injured. And certainly for patients who are in there over the age of 80, those who have got a score of 9 to 15 can sadly die as a result of those. So again, there's lots of focus on looking after our elderly better so that they can recover and get back to a normal function. And below that is the green group. So that's actually the vast majority of trauma. So if somebody falls over in the playground and breaks their leg, they'll sit in that green group. And the vast majority of those patients are all going to continue going to the local hospitals as they would normally do. The group that we want to focus on is particularly those major traumas, those red ones. And we know that if we look after them well, they'll do really well. So this is sadly a real patient who I dealt with. What we actually do is we actually score these in hospital. This isn't done at the side of the road. This patient was hit by a bus and sadly had a really nasty head injury. Also had a flailed chest, which is where ribs are fractured, and had a fractured femur as well. Now what you do is you take the 3 worst injuries, you put them through a really clever calculation, basically square them and then add it up, and as you will see, that patient has a score of 34. So by definition, this patient has got major trauma. They are likely to die unless they get expert care. They've got a really big problem on their hands. The maximum score that you can score is 75, and that's a really, really serious injury. The military have a huge number of patients scoring 75. But what we thankfully see is some of the really good care coming from the military now being spread to the civilian world. So we can see patients with scores of 75 now surviving in the military setting, and we're doing really well in civilian world as well. If we look at the busy times of the day for trauma, no great surprises here. What you will actually see is that I've mapped turquoise as being very high demand, yellow as high, purple as medium demand, and low demand as blue. And no great surprises, you'll see that the vast majority of our major trauma is happening on a Friday and Saturday night, and generally it happens after 3 o'clock in the afternoon. Anyone got any ideas why that may be? It's alcohol. And that's a huge problem for us. Alcohol is something that we really do need to work with because it's a huge demand on our emergency departments, but particularly it causes an awful lot of major trauma. I've got a map here that actually shows you the hotspots of SCAS. Here you go. So you will see that actually we've got some big hotspots. Southampton is actually seeing an awful lot of penetrating trauma now, so we're seeing quite a violent culture there. Portsmouth again has got a hotspot, and then if you go up, Basingstoke is thankfully very civilised, but you still get a little bit of trauma up there. A lot of road traffic collisions sadly on the M3 and on the surrounding roads as well. And then you'll see there's peaks in Slough where you've got lots of inner city problems, and Reading too. So that's quite an interesting map, and we're actually using this as a method of prevention. We can actually go to city councils now and go and name and shame them, and so show them this map and say, look, there's an awful lot of penetrating trauma happening in your area, you need to do something about this. And that's key to this. We need to stop trauma happening in the first place, and that's my absolute passion. But in the interim, we'll deal with it and we'll look after these patients really well. In the UK, we've looked after trauma very well. We've actually looked in South Central Ambulance Service, and we've looked and found that the standard of care is extremely good. We do have the odd mishap. This is an extrication board. The head end has got an orange strap, and as you will see, this patient is sadly 180 degrees the wrong way round on an extrication board. So we do make the odd mistake, but actually we're very good at dealing with major trauma. But historically, we'll see that actually there's been some big problems with the care of patients with trauma. Back in 1992, the Major Trauma Outcome Study Group, they basically said that patients' initial management was unsatisfactory if they had major injuries. They said that patients were treated by junior staff, and I was working in A&E in 1992. I remember how it used to work. You used to have a poor little junior doctor, an SHO, who was being told what to do by the sister in charge. Everyone agree with me? That is exactly how it worked. And thankfully we've moved on an awful lot, and we've now got access to consultants, etc. And actually some high mortality rates. They compared identical patients with the same injury patterns and put them into different hospitals, and they found out that you were 3 times more likely to die in one hospital than another, and ethically that is absolute disaster. There was a confidential inquiry that found that 60% of patients with an injury severity score, so we know that these patients have got major trauma, received a standard of care that was less than good practice. So clearly there were some issues. Actually, that's not very long ago. It's only 7 or 8 years ago. It's actually quite recent. Oh, locked up. Oh, it's done something. Sorry, I don't quite know what happened. And then in 2010, the National Audit Office got hold of all the trauma data and they looked at it in real depth. They said that current services weren't good enough. They estimated that 450 to 600 lives a year could be saved if trauma was dealt with properly. And I have never seen this in a report, but the actual report said the Department of Health must get a grip. And that, as you can imagine, was a massive shake-up. And things have radically changed so that patients with trauma do an awful lot better. We know a few bits and pieces. We certainly know that if you're taken to the wrong hospital, and that doesn't mean whether it's a heart attack, whether it's a stroke, it's far better to be taken straight to the right hospital. So we know that if you go to the wrong hospital, there may be a delay before you're transferred to the area of specialism. We know that patients who end up at the wrong hospital are more likely to die. And we know that patients who are taken straight to the right hospital are more likely to do better. And we've thankfully got fantastic, and I mean fantastic, for example, stroke centres in Winchester. We take patients all the time, and it's very slick and it works great. It's the same with heart attack when we bring patients up to Basingstoke. It's very slick, it works seamlessly, it's great. But with trauma, we tend to take them directly to major trauma centres. And we know that outcomes are better. If we're doing something regularly, we're really good. So if, for example, we only drive once a year, we're probably going to be quite poor. But if we drive every single day of the week, we're probably of a much, much better standard. And we know that if people are doing things over and over, they're certainly much better. This example down at the bottom, this is a patient who's got a bleed outside the brain there. And this patient 5 years ago probably would have died. Now what will happen is you can probably see this sort of lens shape on the bottom left side there. This patient's got a bleed, which if it's taken out, this patient will make a very good recovery and possibly even a full recovery. So the trick is to take this person straight to somewhere with neuro facilities where they can actually do brain surgery and remove this clot and deal with it. And that way that person's more likely to make a recovery and be able to get back to work and have a fairly good quality of life. If a patient goes to the wrong hospital, there have been some audits, and this is across England, not necessarily in this area here, but it's been shown that there's potentially it takes up to 6 hours to get a patient from a local emergency hospital to definitive care. Well, we know that if somebody needs brain surgery, the target time for that is 3 hours. So if it takes 6 hours, that's absolutely crazy. Just occasionally, patients who are really, really sick are taken to the wrong hospital, and that can happen. Of course, if somebody's just too sick to transport, we're going to do that. In which case, SCAS have a very robust time-critical transfer policy. So if, for example, Howard phones up and says, which is very rare, you can't deal with it, you can deal with most things, can't you? But in the event that you can't deal with it, they phone SCAS and they say, I've got a time-critical transfer here, we will treat that with the same priority as a cardiac arrest in the community. So that's treated with an 8-minute response time. We'll send an ambulance there. And we often will question the doctor and say, you realise this is the same urgency as a cardiac arrest, but if a hospital genuinely cannot cope with the patient because they're just too sick, we will treat that with the same urgency as the worst emergency that we can possibly go to. So hopefully that's reassuring. The bits that needed to change to get this system up and working properly, well, pre-hospital care has changed beyond all measure. I'm sure many of you will have seen, for example, the air ambulances flying around. That's a fantastic resource to have. We've now nearly always got access to doctors in the pre-hospital setting. We've done lots of extra training with our crews so that they can give extra medicines, they can use extra equipment, basically managing patients to take them directly to major trauma centres. In terms of acute care, you all have seen, for example, Southampton General now has a landing site outside the front where we can land critically injured patients and then transport them straight in. We've seen an improvement in the resuscitation rooms. We've seen, for example, consultant training in all the trauma units so that our doctors are better trained and are able to deal with acute injuries. In terms of ongoing care, this is where we now have wards that are able to deal with just trauma cases. Historically, we've had wards that have looked after patients with broken legs in the same ward as somebody who's perhaps got a urinary infection next to somebody who's got a chest infection, and it's not a great model. We now have dedicated trauma wards so that if somebody develops a complication, it's recognised by experts, whether they're nurses, physios, OTs, doctors, whoever it is, they are recognised early so that we can do something about it and get these people back into work and get them rehabilitated. And rehabilitation is something we still haven't cracked, but we're definitely on the way there. So in SCAS, we've got 2 major trauma centres. We've got one at the John Radcliffe in Oxford, and we've got University Hospital in Southampton. Now, Department of Health stipulated these. It's not SCAS saying this. We also have another tier, so the major trauma centres will in theory see all of that red group in the pie chart. But then we also have the yellow group and some of the green who go to trauma units. And as you'll see, that Basingstoke is in that list. We work really closely with all of the hospitals here, and what we also see is that patients often are actually the sickest who come to Basingstoke. If they're just too unwell, they've been critically injured in a car accident, and they're just not fit to transfer, then that can be a real challenge, in which case all of those patients will still continue to go to the nearest hospital. And then we have a third tier, which have been, again, stipulated by DH. They're local emergency hospitals. Generally, we don't take trauma to places like Winchester, Wickham, or the Horton, which is over towards sort of Banbury area. We generally try and take trauma to areas that actually look after this properly. And go live was in April 2012. This is a map that shows you where the major trauma centres are across England. They're mapped with little red crosses, and what we've also done is put the drive times on there. If you see light blue, that means you can get to the major trauma centres within 15 minutes, and if you see dark blue, that means that it could potentially take you 120 minutes to get there. This is an absolutely brilliant slide if anyone goes caravanning to show you where not to go. What you will now find is that we're looking at air support here. So air ambulances obviously are critical. If you've got a patient, for example, in Barnstaple, so in sort of North Devon area, currently that sits well outside. It's in the 2-hour drive time towards the major trauma centres. So we're seeing a proliferation of air ambulances that can fly. And in fact, the one in South Central Ambulance Service, the 2 that we've got, we're going to be moving to night flying from November. So at night, we'll have an air support up until 2 o'clock in the morning, when we know that the vast majority of trauma happens during the day and into the evening. Oh, some people may wonder why we've only got 2 major trauma centres. Anyone wondering that? The way it works is you get 1 major trauma centre for every 2 million of your population. So London, for example, have 4 major trauma centres. That's because they've got a population of 8 million. And that's all the clever calculators who have done that, and that's basically how it works. So the trauma units still do a great job. They're going to handle, so for example, Basingstoke are still going to handle the bulk of trauma in the region. Patients who've got limb injuries, those who have got fairly stable trauma. And as I've already mentioned, they may act as an optimising service. If we go to a patient who's critically injured in an accident and we consider that they're just too sick to get down to the major trauma centre, then we'll always come to Basingstoke wherever we can if we're in this region. The trauma units are all held to defined care standards. All patients are put into TARN, which is the Trauma Audit Research Network. That allows us to compare standards across the whole network and across the whole of England to find areas that are doing really well and perhaps those that aren't doing well. And then we can look at areas that are doing well to see what they're doing differently so that hopefully we can bring the whole network up. And the Wessex Trauma Network, which obviously includes this area here, is actually one of the top performing, as I'll show you at the end of the presentation. To help our crews decide whether they go to Basingstoke or whether they go to Southampton, we have what we call a TUB tool, Trauma Unit Bypass Tool. And basically the red box means you probably can't see it, but that's physiological signs. So if they've been involved in trauma and they've got a high respiratory rate or they've got a low blood pressure, then they'll come into there. Below that we've got our injury patterns, and there's a couple of really important caveats which I'm going to go through now. This is absolutely key. If our crews cannot get to a major trauma centre within a 45-minute time window, then they will always go to the nearest trauma unit, which obviously includes Basingstoke. So that's what we tell our crews, and they're very good about doing that. As you will see, our map, which has got our drive times from our major trauma centres, the vast majority of the South Central region can actually be covered by 45 minutes. There is an area near Newbury, which is a bit of a challenge, and what we've done here is we've mapped at normal road speed. You'll be aware that under emergency conditions, the ambulances can go slightly faster, so in reality, nearly the whole of the patch can actually be covered within a 45-minute drive time. Obviously, if somebody's in near cardiac arrest, then they will always go to the nearest hospital, and that actually includes Winchester as well. And then our crews have to ask themselves if they can manage airway and catastrophic hemorrhage. So if they've got an airway problem, somebody's bleeding heavily into their airway and that person's not going to survive, then what we'll do is we'll always transport those people to the nearest available hospital. To make it safe, I'm not going to go through these individually, but our crews have been given a whole load of new medicines, so that allows patients to be transported longer distances safer across the patch, and we've given them lots of new equipment as well, so that they can manage really serious injuries. And I've written there better medical cover. Well, we're very fortunate to have, for example, basics doctors out there who very kindly give up their time, but we've got air ambulances as well. So we now have doctors available to advise the crews, but also to respond to emergencies if they're required. Final two slides. In terms of early results, this doesn't show that well, but there's some extremely good news in this, in that actually what we're seeing here is the odds of survival increasing. We've got on the left-hand side the data from 2008, and you'll see it's in line with the red line. On the right-hand side, we'll actually see that if you're unfortunate to be involved in major trauma, you're 63% less likely to die now than you were prior to 2008. And that's a massive, massive achievement, and probably one of the biggest achievements that we've had in the history of the NHS. So you're 63% less likely to die of major trauma if you're unfortunate to be injured compared to 2008. And my final slide, this is quite sensationalist, as you can see. I had my head cut off and survived. Obviously that isn't quite the case, but this lovely guy is called Jordan Griffin. He was critically injured in a motorcycle accident within this area. Basically, he was very fortunate in that there were experts nearby who were able to give him new medicines. He wasn't taken to Winchester, although the incident happened near Winchester. A lot of care was done at the scene, and then he was transported to the major trauma centre. Now, Jordan is actually back up at work and recently had a child, and I just think it's a fantastic story because this kid would have died 5 years ago. He had the worst injuries. I've seen photos of the injuries, and it's absolutely horrific, and yet he's gone on to make a fantastic recovery. So really, really great news for us. Thank you.